Thank you all for signing into the PedsUroFLO lecture series. My name is Jennifer Singer. I'm a pediatric urologist at UCLA, and I am happy today to be able to talk with you about this topic of pediatric voiding dysfunction. Please go ahead and enter any of your questions in the QA. I'll try to monitor those throughout the time that we're talking. There's also a chat function. I'll be monitoring both of those as we go along and stop intermittently to see if there are any questions along the way. But I did want to just start out by saying that, I fully realize that this topic that we're talking about today is sort of not the sexiest or most interesting topic in pediatric urology. But for me, I think it's a really important topic to talk about. And I saw that not really very many other people who signed up for this had topics like this. And so I always feel like along the way, kind of talking about something really basic, just voiding dysfunction in general, is valuable for all of us who are taking care of pediatric patients, whether it's in primary care or in pediatric urology. I gave this lecture to the COVID lecture series, so for those of you who might have signed on to that, you're welcome to stay, of course, but this is the same lecture I gave to that group as well. So we'll get started now. Just want to overview of the lecture today. Basically, we're talking about voiding dysfunction in kids. And so we'll define voiding dysfunction, very briefly review normal voiding, talk about sort of a little bit of the epidemiology of voiding dysfunction. And really what I want to focus on is presenting some cases, because I think that's really how to anchor the importance and understanding of the topics that we're going over today. So with that, I'll get started. So voiding dysfunction, 30% of children with lower urinary tract symptoms, and up to about 20% of what we see as pediatric urologists is related to voiding dysfunction. It's the most common non-surgical diagnosis that we see. Dysfunctional voiding, not voiding dysfunction, but dysfunctional voiding is a broadly encompassing term, and it's often used inaccurately and applied to any and all voiding problems in children. I want to take some time today to talk about the difference between dysfunctional voiding and voiding dysfunction. The good news about voiding dysfunction is that if we approach it systematically, if you have your own way of approaching it over time, you've learned sort of how you take care of your patients with these problems, we really can help most children conquer their voiding dysfunction. And it's really very satisfying to be able to do that. And it's one of the reasons that I actually enjoy this diagnosis in particular, even though many people find it not quite as fun as obviously taking care of somebody with a more complex urologic diagnosis or being in the operating room doing a pyeloplasty. So I just thought I'd spend a minute just kind of showing you what a typical sort of clinic schedule for me is like, and then focus a little bit on why we're talking about this today. But on a normal day, I'll see, I don't know how many patients, but basically lots of different diagnoses. Penis inconsistent with age, seeing patients about circumcisions, urachal cyst, bedwetting, small testicles, circumcision check, UTI. Another circ patient, testis pain, urinary frequency, dysfunctional voiding, recurrent UTI, urethral valves, multicystic dysplastic kidney, recheck enuresis, hydronephrosis, torsion, and bilaterally undescended testicles. So this is, kind of a normal, typical day. But when I really drilled down on this, these are the patients who actually had voiding dysfunction. So really, again, lots of what we see in pediatric urology. So just a minute about normal voiding cycle. I'm not going to spend a lot of time talking about this, but just as a really brief reminder, obviously voiding is comprised of storage and emptying, and storage is related to bladder relaxation, which is under the thoracolumbar spine control. Urethral sphincter relaxation is under sacral control. So with emptying, the internal and external, I'm trying to get rid of actually this little box, sorry. Internal and external sphincter relax first, followed by a bladder contraction. The bladder is really controlled by three areas of the central nervous system. The cerebral cortex, which provides the highest level of control and is responsible for social and voluntary voiding. The pons, located in the brainstem. This is really where the area of coordination and synergy between detrusor and sphincter occurs, and this is where bladder fullness is detected. And then the sacral micturition center is responsible for reflexive voiding and really infantile voiding. So micturition in young infants is purely reflexive, occurs when the bladder is sufficiently distended to initiate that reflexive response. And about 18 to 24 months, voiding comes under some cortical control. This is interesting for me as I think about families who ask about toilet training earlier. In Europe, toilet training is often started around 12 months of age. But really what we know is that voiding comes under cortical control around 18 to 24 months. So trying earlier than that, which is often successful, is sometimes a little early for kids when you think about the fact that you need some cortical control for toilet training. In about 3 years, complete control is achieved. So again, not going to spend a lot of time talking about this, but voiding is made up of a complex circuit of neural networks and synaptic release of neurotransmitters. So obviously, these messages going through thoracolumbar spine, sacral spine, up to the pons and the cerebral cortex. Associated release of neurotransmitters, including acetylcholine and phosphodiesterase and other neurotransmitters. And then, of course, sort of the coordinated activity of all of these results in normal urinary control and bladder emptying. But things can go wrong. So if any of these areas has a problem or anything goes wrong, we get what's called neurogenic voiding dysfunction. So if things can go wrong in the cerebral cortex, which is again associated with cortical control, highest level of social and voluntary control. The pons is where there's coordination. And really this is where the synergy between detrusor contraction and sphincter relaxation is controlled. Normal relaxation of the bladder, and then sacral micturition reflexive voiding. So anywhere any of these things go wrong, you can get detrusor overactivity, you can get abnormal incontinence from sphincter dysfunction, lots of things can happen. So we're going to talk about voiding dysfunction, and we need to just mention some terms. So voiding dysfunction is a loosely defined term referring to any abnormality in holding and emptying of the urinary bladder. Dysfunctional elimination is really related to urinary voiding dysfunction and bowel dysfunction. But there is a distinction between voiding dysfunction and dysfunctional voiding. And I know that sounds silly to say that there is a distinction, but there really is. Dysfunctional voiding occurs when there's poor coordination between the bladder and the urethra. Specifically, there's a dyssynergy between bladder contraction and sphincteric relaxation. And so we call this detrusor sphincter dyssynergia, where the detrusor muscle contracts with concomitant involuntary urethral sphincter activation. So that's a neurogenic problem if there's involuntary sphincter relaxation related, activation related to a neurologic problem, but this can also be non-neurologic in nature and sort of self-taught. Again, we talked about normal voiding occurring with urethral sphincter relaxation prior to bladder contraction. And if there's a lack of coordination there, we get dyssynergy. So dyssynergy can be neurogenic or it can be non-neurogenic, and that's an important thing to distinguish. The neurogenic causes are obviously things that we need to be able to identify and treat. Non-neurogenic causes also important, but they're in a different category. So there are sort of overall categories of dysfunction with voiding, and there can be the small bladder versus the large bladder problem. So small bladder problems oftentimes present with frequent voiding or frequent warnings and urges, may have accidents, and overactive bladder is typical. The large bladder voiding dysfunction patient oftentimes has infrequent voiding. These can be distended myopathic floppy bladders. These patients oftentimes hold throughout the day. They don't oftentimes recognize warnings that that they have an urge to void. And there can be accidents. We consider these to be underactive bladders. So again, urinary frequency, small capacity, overactivity, plus minus UTIs. Bladder with holding, or the holders may have a large capacity, stretched or weak myopathic bladder may have UTIs, and then the dyssynergic voiding. These are the ones that have the stuttering streams, plus minus UTIs. So what I always think is most important that I talk to the residents about is making sure that we talk about the difference between benign voiding dysfunction and pathologic voiding dysfunction. Benign voiding dysfunction is really the vast majority of the cases, and they're often self-limiting, but they're very distressing to patients and their parents. Oftentimes they come in very upset about this. Children can be in my office in tears and embarrassed about talking about this. It can be really very problematic in the family. They can be related to stressful events like new school or new siblings. These often recur throughout childhood. So these benign voiding dysfunction cases can occur for a variety of reasons, and they can come and go. Oftentimes associated with stool withholding or constipation, may be associated with simple cystitis, but the benign voiding dysfunction is not associated with hydronephrosis, secondary reflux, or bladder trabeculation. The Pathologic voiding dysfunction is different, though. These are more problematic and more dangerous with their potential effects on the upper tract and accidents and bladder dysfunction. These patients tend to have persistent, chronic, and unremitting problems, and they're generally not self-limiting, oftentimes requiring some sort of intervention. They can be progressive, and if severe, may lead to bladder and renal dysfunction. So we all know that Hinman syndrome, the non-neurogenic, neurogenic bladder dysfunction. Often associated with chronic constipation, stool impaction, and encopresis, and urinary tract imaging for these patients may be abnormal. We may say hydronephrosis, abnormal bladder contour with trabeculation, secondary reflux, abnormal cystometry on urodynamics, and we'll talk about that. So how do we evaluate patients with abnormal voiding? And basically, it's like any other patient. We do a full medical history with an expanded voiding history. Important, obviously, to do a full physical exam, which I think is something that lots of folks sort of skip when they're talking to patients about bedwetting or other wetting problems. And really, oftentimes, you can pick up something very important, which can be obvious or subtle. The physical exam is really important. So spine, coordination, EU exam. Consideration of labs, so urinalysis, of course, is important. Want to make sure that we're not missing anything like proteinuria or any other findings on urinalysis. Culture, if indicated, rarely we have to do a creatinine, but sometimes I'll do that for patients who might have pathologic voiding dysfunction and secondary changes. If we think we're dealing with a diabetic, fasting blood glucose, and then we talk about imaging. So again, this is really the most important thing, and kind of one of the take-home messages for me about this topic is really listening well. Oftentimes, people who do not enjoy talking with patients about voiding dysfunction hear the same thing no matter what the patient is telling them, because you can sort of tune out, unfortunately, and not pick up the very important sort of subtle things that you'll hear from patients. So it's really important when you walk into a room with these patients to take a deep breath, understand you have to sort of sit through this and think about it, but knowing that you can help these patients if you really get to the bottom of their symptoms is the thing that drives me to want to do this properly. So, you know, full voiding history includes toilet training. So when was it done? Was it easy or was it difficult? What are the characteristics of their complaint? Is it urinary urgency and frequency? Is it holding for long intervals? Do they have dribbling, leakage, full abstinence? Do they have a strong, weak, or intermittent stuttering stream? Does this occur only at daytime, only at nighttime, or both? Is there an associated problem with constipation and encopresis? What other medical problems do these children have? Obviously, the kids with developmental delay or later to achieve continence, lower extremity coordination like spinal cord questions, and what is the age at presentation? So don't forget to think about tethered cord and ask about coordination. So a second, just one slide on tethered cord. This is a neurologic disorder caused by tissue attachments that limit the movement of the spinal cord within the column and can cause an abnormal stretching of the spinal cord. It is most evident in infancy, but if not in infancy, then at around age 6 when children go through growth spurts, and the elongation of the spinal cord can result in worsening stretching and more problems with bladder and bowel dysfunction. Moving to the next slide, I'm just stopping here to check at the chat or any questions. If you guys have any, please go ahead and submit them. I'll stop intermittently. So more about the evaluation. So physical exam, of course, as I had mentioned, is important. You want to assess for any masses that you might feel, like constipation, bladder distension, or tenderness. In the female, always examine their introitus, make sure it's patent. Something as simple as complete labial adhesions may trap urine with vaginal voiding, and their accidents may be entirely just vaginal voiding. Are there signs of infection, chronic infection? Are there signs that you can see anything on your exam that there's an infection? For males, you always want to check to make sure their meatus is normal. I've seen kids who have just meatal stenosis who have issues with accidents from incomplete voiding. So something as simple as a meatal stenosis can be captured just by your physical exam. Lower extremity exams, critical for anybody coming in with voiding dysfunction complaints. You want to do a full neuro exam, make sure it's normal. Look at their sacrum, make sure there's no dimpling or pitting. Check their coordination, look at their feet. And then move on to their lab. So we talked about the urinalysis for signs of infection or proteinuria, and again, any associated necessary blood tests. So here's really where I think sort of understanding and listening to patients will drive the further part of your evaluation with any sort of additional testing or imaging. Not every patient needs any of this. Some patients need all of this. And so it's important to sort of try to determine and decipher which kids will benefit from which of these evaluative options. So for me, the two most common things that I will order in children who come in with varieties of voiding dysfunction is UroFLO and PVR. So uroflowmetry is a critical part of my evaluation, and then a KUB. We'll talk about why. So for UroFLO and PVR, you want to make sure that you're evaluating their the size of their bladder. Do they have overactivity, evidence of overactivity? Is there intermittency or stuttering of the stream? Do they have a normal bell-shaped curve? Renal and bladder ultrasound is almost never going to give you any additional information in kids unless there's a really unusual consideration that you might hear about when you're taking their history. And so this is usually going to be normal, but not always. KUB. So one of the most common things that I'll see with kids who have voiding dysfunction is constipation. It is a very, very problematic issue with bladder function, and bladder dysfunction related to constipation is a primary consideration for these kids. So oftentimes I will do this. Even if I think that they have it, I want to share this with the parents and make sure they understand how important it is. And when I can show them the KUB that demonstrates this, it oftentimes takes that message home. Look at their bony structures. Rarely I'll do a VCUG or urodynamics. It really just depends on the patient's presentation, if they're presenting with any other signs or symptoms that make me nervous and I need to know more, or if they have recurrent infections or certainly any febrile infections. So KUB for constipation, this is just a nice little cartoon of the importance of understanding how this sort of rectal fecal mass can push on the base of the bladder and wreak havoc. And so we can see a lot of dysfunction just related to sort of this overactivity from this constipation burden. Also, kids can have, or adults can have difficulty emptying their bladders to completion. You might have a weak stream, you may have an elevated PVR and recurrent infections, and all just related to chronic. So everybody on this call knows what uroflowmetry is, but basically simple in-clinic test to measure bladder capacity, urine flow characteristics, including the peak flow, time to initiate voiding, time to completion of voiding. And again, a high peak flow may indicate bladder overactivity. A stuttering stream may indicate intermittency or DSD, detrusor sphincter dyssynergia. Prolonged emptying, weak stream, or small capacity may indicate obstruction, can be found in patients with constipation. And then if you can add patch electrodes, you can learn a little bit more about the neural innervation of the perineum and whether or not there's a properly associated synergy there. For PVR measurements, so most children should empty their bladders to completion. It is normal to retain up to about 10% of bladder capacity in children. Anything greater than that, you want to take pause and consider that that could be from impatient voiding. So I talk a lot with kids about making sure they're waiting long enough. Kids oftentimes want to just stop short and get back to playing. And so if they do that, you may have an elevated PVR. Do they have a weak bladder from prolonged holding and development of myopathy over time? So are they not emptying for that reason? Could there be obstruction from constipation or something more pathologic that's resulting in an elevated PVR? And so this is sort of in my back pocket for kids with voiding dysfunction, whether or not I want to have a more formal assessment of bladder function. And obviously for that, we can leverage urodynamics or video urodynamics. So this is, going to give us more information about the dynamics of their bladder, sphincter coordination or relaxation, pelvic floor innervation, voiding patterns. If you add video or fluoroscopy, you can get a nice sense of what the bladder looks like during voiding. And oftentimes the shape of the bladder during voiding can give you your answer. So another couple of pictures just to kind of drive home the importance of distinguishing benign from pathologic voiding dysfunction. This is just a cartoon, obviously, of what can really happen with, patients who have obviously severe trabeculation here that you see on this actual cystoscopic image. But, even kids with just voiding dysfunction can end up having these trabeculated Christmas tree appearances of their bladders, secondary reflux with diverticuli. You can see some hydronephrosis on ultrasound in these sort of more severe or advanced cases, and again, another sort of end-stage bladder. So what are the treatment options for voiding dysfunction? Well, it's most important to understand that you have to individualize these based on the patient's presentation. And so there is not one sort of treatment protocol for all voiding dysfunction, of course. So in our armamentarium of options are the following. So obviously, we talk a lot about voiding schedules, voiding diaries, alarm watches that they can set to remind themselves when to go, and very importantly, school notes. So it's not it may be surprising to understand that there's a lot of times that I'm writing notes to schools because teachers are requiring tokens, or kids have to sort of give something up to be able to use bathroom breaks. One of the things I always tell all the kids, though, is you have normal breaks that are scheduled within your day. So you have recesses and you have a lunch break. Those are the times that that are intended for you to actually pay attention to your bowel, your bladder, and eat and relax. And so during those times, you should be using the restroom. If outside of that, you're needing to do additional bathroom visits, and that's when it's an appropriate thing. So making sure the kids understand that they shouldn't rely on a school note and then have their recess just go out and play and not pay attention to the actual reasons they have those breaks is important to make sure that you're communicating that. I'm going to stop for a second because I see a question. Yeah, so indications for urodynamics, any preference about the age to do that. So I'm going to show you, I think I have 5 or 6 case presentations, and I really want to focus on those as to sort of how I think about when to do urodynamics for these voiding dysfunction kids. Absolutely, it's a rare thing, and we'll talk about that a little bit more, and if I don't answer that question, please resubmit the question to me. Okay, so in addition to those obvious voiding schedule things, management of constipation. So the most important is dietary fiber and hydration. I use a lot of fiber gummies in my practice. The sugar-free ones are best. Miralax, mineral oil, and I oftentimes will actually do full bowel cleanses for these kids who are chronically constipated, and it's really amazing how just managing their constipation can get them over a lot of their voiding dysfunction if it's related to that. Depending on their diagnosis, we may or may not sort of initiate an anticholinergic therapy option. Only CIC for those kids who really have problems. We'll talk about that, but every once in a while with a kid who has really severe DSD, sorry. So kids who have severe DSD, we'll talk about whether or not intermittent cath is indicated. Alpha blockers to relax the sphincter for kids with DSD is occasionally indicated as well. So for these kids, really prompt treatment of UTIs is important. When kids get in a sort of a cycle of recurrent infections, their voiding dysfunction will be worse. The bladder tends to be angry, can get inflamed, and that sort of propagates the process. So of course, attending to UTIs. So we'll talk a little bit about biofeedback. So biofeedback is like physical therapy for the bladder. And so it's utilized to train children to recognize their bladder filling, their sensations of bladder filling and emptying, and to learn to control and properly manage the urethral sphincter and how to relax it. The issue with biofeedback, there's several. One, it's not covered by all health insurance, and so it can be expensive, and some families can't afford it. It's not widely available, so it's not available at every health system, as you probably know. It's not available sort of in every city, and so some people just don't have access to it. For me, the most important thing is really the quality of therapists. So this is really important, and I think for me, one of the reasons I do urodynamics in the kids that I send for biofeedback is because it's important to let the therapist know what you're treating. The diagnosis can be very different, and then the treatment course by biofeedback should follow that. Oftentimes, when I send kids to biofeedback and they find a place to go on their own, they come back telling me that they were taught to do Kegels. And so that's pretty typical. So Kegels, basically learning how to contract your sphincter, is pretty typically the fallback for most biofeedback therapists that I've at least experienced in non-children's hospitals or in areas that take care of children frequently. And the problem with that is if you're trying to manage somebody with detrusor sphincter dyssynergia, they actually need the opposite of that. They need to learn how to relax their sphincters, not how to make them more clamped. And so oftentimes that, for me, the quality of the therapist is actually completely related to how they're actually going to be successful or not with the treatment course. So again, treatment of voiding dysfunction, sometimes we'll use medications, anticholinergic therapy to relax the bladder, alpha blockers to relax the sphincter, and some combination thereof, potentially. So I'm going to move on to these case presentations now, and I think I want to spend some time really focusing on these because I think these really do, for me, highlight how important it is to be able to listen to the patient's presentations and think about the differences. So these are just 4 of the ones we're going to talk about, and these were sort of the presenting tales that I was told by their parents. So first patient, she has accidents throughout the day, and she says she can't tell when she has to. Second patient, she has to void every 15 minutes. We can't even take a car ride without pulling over. Third patient, she has to void too frequently. She wets during the day and night. The teachers are complaining. And fourth patient, he's having accidents, he's lazy, he poops in his underwear. And so, you know, these first three patients, many sort of providers might hear something very similar. They may feel like this is the same presentation, but you'll see as we go through these that they're very different. So the first patient, again, so this is a 10-year-old. She has accidents throughout the day, and she says she can't tell when she has to go. This is a 10-year-old female. Her voiding history is that she toilet trained normally at around age 2. She has daytime full voiding accidents that have been on and off for many years. She reports that she doesn't feel her bladder or the warnings or urges to void. The voiding frequency is unknown. So this is pretty classic. If I look to a patient or a parent and I say, well, how often are you going to the bathroom? Oftentimes they just look at me and say they don't know. And so something as simple as just saying, well, do you go to the bathroom as often as your sister or brother? Or do you go to the bathroom more often or less often? They still sometimes don't know. And I have to send them home really paying attention to their voiding frequency, which can be really important in sort of understanding what kind of patient we're dealing with. Oh, did something happen with my screen? Uh-oh. Let's see. Let me try this again. So I'm not sure if all of you realize what's been happening with Zoom, but there have been a lot of blackouts on Zoom. So can you guys, I just stopped and restarted. Can you see my screen? Yes. Oh, hooray. Okay. Thank you for letting me know. So again, 10-year-old female, normal toilet training, daytime full voiding accidents on and off for many years, doesn't feel her bladder warnings or the urge to void, doesn't really know her voiding frequency. They say it seems normal. Occasional simple bladder infections and a history of on and off some constipation, not too notable. So this, you know, I'm typically going to do this. Uh-oh, another problem here. Can't see my screen. Gone again. Let's see. Okay. Is that better? Can you guys see my screen? No. Nope. It was there for a second and went away. So Michelle, I think I'm going to log out. I think I have to and log back in. Is there a second that went away? Let's see. Let me try one more time. Okay, let me know if you guys see it now. Anyone can let me know if you can see it now? Yes, okay, perfect. All right, I'll keep an eye on the chat. Not sure why that's happening. Okay, so again, we're on the first case, 10-year-old girl. So again, I almost always will do a UroFLO on these patients. Always get a urinalysis first. Typically, those are going to be pretty normal. So urinalysis is normal, did a UroFLO, and obviously I knew immediately what was going on with her. So she voided 780 mLs for a 10-year-old girl. Had a nice strong stream, normal bell-shaped curve, PVR 49. So this might seem like a lot for a kid, but again, less than 10% of bladder volume is considered normal. So she's less than 78 cc, so this is pretty normal. So I already know that this is probably a holder. If I look, I did, and rarely will I do a renal and bladder ultrasound. I'm using some cases just to illustrate my point. Normally I would not do one, but we did do one for her. Normal kidneys, really, oh no, it's gone again. I can share my screen with your slides if it happens. So can you guys let me know if you can't see? Sorry, this is happening, everyone. Can you see, can anybody send me a quick chat? Great, thank you. Okay, so enlarged bladder, so obviously big bladder. She had a normal KUB, so nothing too remarkable. So basically we knew that this is just a benign voiding dysfunction, urinary holder with large capacity bladder. Put her on just a regular voiding schedule, voiding diary, timed voiding, alarm watch, and simple note. She did great, did much better. That's all it took. So basically something as simple as just talking to parents and talking to children about what's normal voiding can sometimes just make this go away. Case 2. So this is a girl who has to void every 15 minutes. We can't even take a car ride without pulling over. So she's a 7-year-old female, had normal toilet training. She had diurnal enuresis beginning at age 4. So she was dry during the day at age 2, but around age 4 started having accidents during the day, never got dry at night. She's voiding frequently, every 15 to 30 minutes throughout the day. This is disruptive at school, home, and in car rides. She does not get UTIs, no history of constipation, no encopresis. So for her, again, this is a rare patient on whom I'm going to do an ultrasound, but I want to show some cases here to just illustrate some points. So for her, I'm going to go here first to show you. No, actually, I don't have her here. Sorry. So kidneys are normal. Bladder is small, but could maybe just not be full, but big rectal burden here. So there's big rectal stool burden right here. On KUB, massive amount of constipation. So full throughout the whole colon, full in the whole left colon, full rectal burden of stool. For her, this is a kid who had other reasons to do this. I would not normally do urodynamics in this child, but this is again just to illustrate a point. So this is a child who has frequent visits to the bathroom and accidents throughout the day and night. So the way we do urodynamics in my center, we get a minimum acceptable bladder capacity and the average bladder capacity for this patient's age and weight. So minimum would be 214 mils, 330 is average. She just had adequate sort of acceptable bladder capacity, but on the small side. She's a normal looking bladder. Her compliance is normal. She has normal kind of urethral relaxation with bladder emptying. So again, the urethra relaxes before the bladder contracts. So normal urodynamics, of course, for this patient. Normal funneling of the bladder when she voids, pretty nice smooth bladder. So nothing abnormal here. So this is a child who also has benign voiding dysfunction. So urinary frequency with small capacity bladder. So for this child, we talked about avoiding diarrhea with stretch intervals. With school notes if needed, management of constipation, increasing hydration. We manage her constipation with fiber gummies and some Miralax. If a child like this fails, and after you manage constipation, a short course of anticholinergics to allow that bladder to start stretching or relaxing may be helpful. Case 3. So this is an 8-year-old female who also voids too frequently. It's on again. Slide's not advancing. Okay, Michelle, do you think you can share your screen and I'll just ask you to advance? How should we do that?
Yes, I can do that.
Okay, thanks. Should I stop sharing?
Yes.
Okay. So I don't see anything, but I'm guessing you're not sharing yet. Let me know. Okay, perfect. Ah, there we go. Thank you, thank you. Okay. Shared content is fit to your screen. So is this the mode that we want to see it in? I see the next slide. Is that intentional for just me only, Michelle?
Let me fix that. Hold on 1 minute.
If you can just show it in the same mode before, I don't need to see the next slide in presenter mode if possible, but I can work however works to show it to me. Okay, perfect. I think if we go back a slide now. Okay, perfect. Thank you. All right, so so this is an 8-year-old female. She toilet trained normally, developed accidents shortly after. Also has diurnal wetting. She has a history of known constipation, but she's also voiding frequently. So every 30 minutes throughout the day, again, disruptive. This child is a little different than the last one, and she's having several episodes of simple cystitis. Next slide, please. So this is her uroflowmetry. So immediately we can see something different. She's got, for an 8-year-old, she's got a small bladder volume, but her most notable finding is this sort of intermittency. So this always gives me pause if a child has intermittency on their uroflowmetry. I always consider whether or not this might be DSD. So this is her imaging. So normal kidneys, normal bladder, pretty normal KUB, a little bit of stool burden there. Next slide. So some constipation, but not as bad as the last patient, but still something to work on. Next slide, please. And so for this, if I do see a stuttering stream on uroflowmetry, I will oftentimes consider during urodynamics. And the reason that I do that is for this particular patient. So this is a child who has a very small capacity bladder. I don't have a pointer I can use, unfortunately, because Michelle is directing the slides. But basically, her bladder capacity is 119 milliliters. That should be at least 230, so it's about half the size it should be. Her compliance is okay until she actually reaches her capacity. She does have a moderate leak point pressure, and she has some intermittent leakage. Here, though, what is most notable is that she does not have normal synergy between her urethra and her bladder contraction. So if you look at the urethral phase, which is the third row on the urodynamics on the top right, the urethra actually contracts before voiding. And so here we see dyssynergy. The urethra is not relaxing with voiding. And so these are the kids that I really do worry about may not have actually benign voiding dysfunction. If you just listen to her history, it doesn't sound all that different from the last patient, but her uroflowmetry was very different. And so you can see in sort of the cystogram phases that she's got this sort of spinning top deformity. And you see these little bladder ears on the right panel of the cystogram. You can see these sort of bladder ears at the base of the bladder, and that is from pressure voiding against a closed door. Her sphincter has contracted, and she is voiding against that. So the bladder starts to get deconditioned over time. Next slide. And here you can see that's why we call it the spinning top deformity. So basically the bladder neck and proximal urethra was sort of billow open against this closed door of the external sphincter. Next slide. So this is a patient who actually has pathologic voiding dysfunction. So we would call this sort of non-neurogenic detrusor sphincter dysynergia. And I know that it's non-neurogenic because she had an MRI of her spine because of her abnormal urodynamics, and her spine was normal. So this really, we spend a lot more time with this child with management and treatment. So we manage her constipation, increase hydration for stretch and distending bladder capacity, voiding diary, timed and patient voiding. So the most important thing here is patient voiding with attempts to stretch the voiding intervals. And so what we've got to get these children to do is relax their sphincter and avoid volitional dysynergic voiding. So these kids oftentimes really do benefit from biofeedback. But if I sent this to sort of my average biofeedback therapist who taught her how to do Kegels, the problem gets worse and doesn't get better. This is why sending them with urodynamics and a report is important to make sure the therapist understands we're working on relaxation during voiding and not other. So anticholinergic therapy may be helpful to help the bladder increase in its capacity. Sometimes that makes the PVR worse though. Alpha blockade can help to try to relax the sphincter. So I have seen some cases where I just use a little cardura and it actually can help. And then if anticholinergic therapy results in retention, these are the kids who sometimes end up on temporary CIC as we work on trying to manage their overall individual therapeutic plan. Next slide. Okay, so this next patient is a 28-year-old who came to me with chronic kidney disease of unknown etiology. So he was referred to us for findings of severe bilateral hydronephrosis. And when I talked to him, he reported sort of voiding with a weak and dribbling stream. Next slide. So this is his imaging. This was done during a renal transplant evaluation. So really thin bilateral renal parenchyma, massive hydronephrosis, hydroureter as well, all the way down. His bladder in the middle column, basically, you can see a diverticulation, bladder is thick-walled. And on the right side here is his voiding phase of a VCUG showing a severely abnormal trabeculated bladder with significant diverticulation. Next slide. So this is this patient's urodynamics. So he basically has this very abnormal appearing bladder, very small capacity. His compliance is poor. So obviously you can see that on the top panel of on the right top panel, the first column is his voiding, the first three. So basically 1 and 3 are vesicle and detrusor pressures. And then the bottom one here is his urethral phase. So he's got poor compliance and he has absence of urethral relaxation. So here we don't actually see him sort of contracting his sphincter, but he doesn't relax it. He dribbles and is in retention, severe trabeculation, normal spinal cord MRI. So next slide, please. So I wanted to highlight the difference between that last case and this case, and just show you that 20 more years of patient 3 can become patient 4. So it's not that different. You sort of see these, this kind of advanced spinning top deformity on the right, but the spinning top deformity with these bladder-based ears and a more smooth bladder but of small capacity over 20 years becomes this sort of right panel. So this is a patient who just had non-neurogenic voiding dysfunction, who had worsening of his bladder function over time to the point that he developed secondary changes with renal dysfunction, renal failure. So this is why I feel like it's so important really to understand these patients. The vast majority of dysfunctional voiders are the ones that are going to be benign. But if you don't listen to these patients and find out which ones are in these categories, this is what we can see happening to the patient population. Next slide, please. I think back one slide, please. Thank you. So pathologic voiding dysfunction, Hinman syndrome. This patient had a bladder augment with lifelong clean intermittent catheterization and renal transplantation. Next slide, please. So this is my final case. So this is a 6-year-old whose parents brought him in because he's having accidents of urine. He's lazy and he's also having stool accidents. They toilet trained him normally. Everything was fine after that. He was dry day and night, but he developed diurnal enuresis and encopresis at age 5. So whenever I hear encopresis, I always take a pause and really want to think about that. That's more worrisome than bladder accidents alone. This patient does not have UTIs. And when I asked him, what his symptoms are, he says, I don't feel when I have to go. I just simply can't tell. He doesn't get any urges, no warnings. And really, digging in here, this is a really normal kid. No apparent behavioral concerns, no ADHD. He's a great student. And really trying to understand why this is happening. Kids don't want to have accidents. They don't want to be stooling in their underwear. So really trying to get to the bottom of this, listening to the patients is very helpful. So what's hard for me to hear is that families try punishment sometimes. And oftentimes these kids really have issues that are completely out of their control. So trying punishments with them is oftentimes heartbreaking when we realize that they may have something more going on. Next slide. So this patient had a normal renal ultrasound. KUB showed a large stool burden. Next slide. And this isn't actually, this is his cystogram, but not his urodynamics. But this is what I saw on his urodynamics, which is basically the stuttering urethral pressure profilometry. So he really has dysynergic voiding with this sort of stuttering urethral contraction throughout the voiding phase. And next slide. So this patient ended up having urodynamics that showed that he retains urine with sphincter dyssynergy, and essentially his spinal MRI showed a tethered cord. So this is a patient who we captured really listening to his symptoms and testing him appropriately, showed he had a tethered cord. Next slide. Diagnosis is, again, pathologic voiding dysfunction. He ended up having pretty classic neurogenic bowel and bladder dysfunction related to his tethered cord, underwent an L4 laminectomy with detethering and did well. Now he's 12 years follow-up, all symptoms resolved, and he's doing great. So next slide, please. So really in summary, the reason I always want to talk to groups like you about this is that I think while voiding dysfunction is common, it's super important to identify the category that we're dealing with, important to differentiate benign from neurogenic etiologies, and understand that we can successfully manage these kids when we really take a thorough evaluation and adapt an appropriate individualized treatment plan based on their patient presentation. I'll stop for a second just to mention that I do not routinely do urodynamics or even renal ultrasounds on most of these patients. I think the patients who really do sound like they have benign voiding dysfunction are oftentimes very easy to figure out just from a uroflowmetry and from a KUB. The problem that I have with UroFLO is getting it right. If you don't get a child to hold their bladder and fill their bladder until they really have met their capacity, oftentimes you can overestimate a small capacity bladder. Asking a child to wait until they really have to go for uroflowmetry is not always that successful. So in some patients in whom I really feel that I have to understand something more, urodynamics really does provide that additional information that got us from patient 2 that was a frequent voider with a normal bladder and normal urodynamics to patient 3 who had DSD and the development of an abnormal neurogenic appearing bladder. So it really is about years, I guess, of some experience, knowing which patients really benefit from which appropriate evaluative processes are going to help us differentiate these. But it is really about listening to the patient and getting to their symptoms to sort of figure it out, right? So for me, UroFLO, urinalysis, KUB are routine, and then additional testing based on sort of symptoms and results of those tests. Next slide. So the last thing I just want to mention is that obviously in all the programs that you guys are in, voiding dysfunction is managed differently. So in some programs like mine, we just do that primarily as the pediatric urologist. We do not have a voiding dysfunction clinic. But there are programs where there's MD and physician extender sharing of these patients, with physician extenders seeing them primarily and conferring with physicians when things either need oversight or where more additional help is sought. And these voiding dysfunction programs oftentimes are coordinated with multidisciplinary teams, incorporating MD, physician extenders, and how to incorporate biofeedback programs based on your local area is also pretty important in trying to get these patients properly cared for and doing it right. So with that, I think next slide is, and then next slide, sorry, one more please. So so Michelle asked me for you all to please take a picture of this QR code for some thoughts about this lecture today. Appreciate any feedback, and I will I will answer any questions that I see now. So let me see if, okay, I can see your question. So Hinman syndrome in children. So, you know, it's not really, it's really, Hinman syndrome is basically non-neurogenic, neurogenic bladder dysfunction. It's a diagnosis that's made both in children and adults. If you see a child who basically has, so if, Michelle, do you mind going back to patient 4? Yeah, keep going, please. Yeah, so so this patient, sorry, let's go to patient 3 for a second. So this patient really just has, thank you. So this was a child, yeah, we can stop here, great. So this is a child who really doesn't have Hinman syndrome. This is just a child who has voiding dysfunction. But eventually, if we don't manage her detrusor sphincter dyssynergia, which is not neurologic in nature. So this patient has intermittency or strain, which Michelle just showed you. And then if you go two forward here, one more, sorry. Okay, so here you can see this is an abnormal bladder. And so she does have this detrusor sphincter dyssynergia, but it's not related to an abnormal neurologic condition. She has a normal spine. So if you identify a child who has a neurogenic bladder dysfunction and has a normal spine on MRI, that is a non-neurogenic voiding dysfunction, non-neurogenic neurogenic bladder. This one really, she has voiding dysfunction with DSD, and so I wouldn't necessarily put her in the category of a Hinman syndrome. But the next patient, if we can go to slide, yeah, keep going. So this one, keep going. Yeah, one more. So this patient really does have sort of an advanced neurogenic bladder dysfunction. But again, he has a normal spine, so there's really no neurologic component to this. And this is really self-taught. We don't know how children sort of develop this or teach themselves these habits that make their bladders become like this. But my theory is that, you know, kids who were either impatient voiders in childhood, so I don't know how many times, you know, we talk to kids about being patient with their voiding and not stopping short to get back to the playground or get back to their video games. You know, they do their potty dance, they don't want to stop their enjoyable activities, and when they go to the bathroom, they pee for 20 seconds and then stop short. If you clench your sphincter while your bladder is still trying to empty, that really becomes DSD. So urethral closure during detrusor contraction will result in this pattern. And so if you do that over a period of years, you ultimately have this is self-learned activity, which is really what I think is the basis of Hinman syndrome, non-neurogenic, neurogenic bladder dysfunction. I think, you know, there's lots of reasons that kids teach themselves to stop voiding while their bladder still wants to be voiding. I had another child who was afraid that there were ghosts in the bathroom, and so he would void as short a period of time as possible and ended up in renal failure, just like this patient number 4. Had a very similar appearance, but a normal spinal cord MRI, but with a very advanced neurogenic bladder. So it's a non-neurologic neurogenic voiding dysfunction that can progress to end-stage renal disease and untreated. Okay, so that's that. So I don't see any other questions from the group, and I don't think I see anything on the chat. I'll give another, here's another question. Oh, you're welcome. Thank you very much. So I don't see any other questions. With that, if you guys have any questions going forward, my email is I should have put that on the slide, it's jsinger@mednet, mednet.ucla.edu, jsinger@mednet.ucla.edu. I'm happy to answer any questions anytime. Appreciate the opportunity to be with you guys this afternoon. I hope you all stay safe and healthy out there, and look forward to meeting you all guys in the future at various meetings, and reach out with any questions or comments, and have a great rest of your afternoon. Signing off. Bye-bye.